Brendan Kelly is my name. I'm a psychiatrist at the Mater Hospital and a senior lecturer at UCD. And I'm going to talk about mental health legislation and human rights in Ireland. This is a topical issue. The Mental Health Act 2001 is currently being revised. There is an interim report with suggested revisions, and that's now being considered by an expert group appointed by the Minister. And there will be changes to the legislation within the next year or two. And this is important. The human rights aspect of this is clearly important. If we go way back in the past to 1817, when Ireland was a part of the United Kingdom of Great Britain and Ireland, they sent a commission to Ireland to look at the fate of the lunatic poor. And they found that when a strong man or woman develops mental disorder in Ireland, the only way they manage is by making a hole in the floor of a cabin, not high enough for the person to stand up in, with a crib over it to prevent him getting up. The hole is 5 feet deep. They give the wretched being his food here, and there he dies. So there is an idea that prior to the asylums in Ireland, the mentally ill lived charmed lives on the village green, and the baker gave them bread, and they slept in the farmer's barn, and so on. And that is just not true. At that time, people with mental illness died young and badly. This couldn't happen today, right? Well, the Guardian newspaper, reporting from central London in 2010, wrote that this man was found dead from heart disease with hypothermia. He was a man with schizophrenia. He lived in a damp, freezing flat with mold on the floor and exposed electrical wires. Boiler broken, bathroom collapsed, and there was a smell. His conditions were dreadful. Despite 4 years of pleading from the family, NHS staff would not intervene, thinking they would be violating his human rights. So in the human rights sort of discourse, this is known as he died with his human rights perfectly intact. All right? And this is, how has this come to happen, that human rights have ended up not working for individuals? And this is what I want to talk a little bit about today, especially in the context of mental health. So what are human rights? This is Eleanor Roosevelt with the Universal Declaration of Human Rights made out by the UN. A human right is something you're entitled to by virtue of the fact that you are human. There's no other qualification needed. You don't need to have capacity or not have capacity, or be rich or poor. You have a human right because you're a human being. People don't grant you rights. They don't take them away either. You still have them all the time. All that's happening is they're being recognized or they're being violated. But you have the rights. And there are two kinds, civil and political rights, things like not getting put in prison arbitrarily and voting. And then the economic and social rights are ones that are to be achieved progressively by countries, like the right to healthcare, the right to a standard of living, and so forth. These rights depend on how wealthy or poor a country is, and they generally have less of an edge to them than the civil and political rights. But that's what human rights are. And why do we talk about these in relation to mental health law? Well, I think I've already shown that people with mental illness, especially severe mental illness, tend not to get an equal sort of bite of the apple. Even equality legislation is often difficult for them to access and to make work for them the way that other people can make it work. And the history of psychiatry in this regard isn't exactly thrilling. When you look at the institutions and the asylums and the kinds of treatments that have happened in the past, it's not particularly uplifting. Now, there were good moments. There have always been reformist movements, like the famous Pinel, but these have always been balanced by large custodial asylums, such as Bethlehem and indeed elsewhere. And some of you will have seen a TV program about the asylums in Ireland, maybe last year. You can still see it on the internet. Looking at the growth of these institutions and how large public institutions with up to 2,500 people in them grew in Ireland and elsewhere. And they grew because of a broad societal complicity. Families keen to move people on, families who couldn't cope, and human rights were certainly abused. So what are the standards we're looking for in a law? Well, the legally binding document here is the European Convention on Human Rights. And it's worth reading through this. Everyone has the right to liberty and security of person. No one shall be deprived of liberty save in the following cases and in accordance with the procedure prescribed by law. And one of these is the lawful detention of persons for preventing infectious diseases, persons of unsound mind, people with alcohol problems, or people with substance misuse problems, or vagrants of all things. So this is the European Convention, and it's obviously several decades old, so the language is objectionable by today's standards. But it says that people in these categories can be deprived of their liberty if there is a national law permitting it. Do we have a national law for detaining people to prevent spreading infectious diseases? Anyone? Yes, we do. In certain specific cases, for example, open TB, if people aren't taking medication, they can be detained or compelled to take medication in the public good. Do we have a law for the detention of persons of unsound mind? Yes, we do. Amongst others, we have the Mental Health Act 2001. Do we have a law for detaining people who have alcohol or drug problems only? No, we explicitly do not have such a law. And do we have a law for detaining vagrants simply on the ground that they are vagrants? We do not, thankfully. But if we had, it would not represent a violation of the human rights standards. And the other point of relevance here, everyone deprived of liberty by arrest or detention shall be entitled to take proceedings by which the lawfulness of detention shall be decided speedily by a court and release ordered. So do we have, for persons detained under the Mental Health Act, are they entitled to take proceedings? Yes, in fact, we exceed that. We force them to take proceedings. There must be a mental health tribunal. One of the suggestions in the interim report revising the Act, is that people should be able to waive the right to a tribunal if they don't want it and if they possess capacity. But in any case, we now exceed this requirement. And who decides the lawfulness of the detention? Is it a court in Ireland? It's a tribunal. But there's good precedent from Europe that tribunals, once they are properly composed, independent in character and judicial in nature, count as courts. And it must be speedily. How soon do you have a tribunal if you're detained under the Mental Health Act? Within how many days? 21 days. Is that speedily? Who thinks it's speedily? Okay, a small number of people think it's speedily. Thanks, Eric. You're the only one. Does anyone think it's not speedy? 21 days. Well, it's hard to know. The European courts have ruled on specific cases. 55 days, which was the case in Finland, is not speedy by any means. 14 days is speedy. So we're probably there or thereabouts, according to the European courts. And can a tribunal order the release of the individual? It can, yeah. It used to be the case, but they pretty quickly fixed that. So they're what we need to adhere to in terms of hard European human rights standards. These are legally binding. There's only one place there where I would have an issue, which is about a tribunal being a court. One of the characteristics of a court is that it generates case law, so that if someone going in front of a court has the opportunity to look at previous judgments so as to present their case as best as possible. Do mental health tribunals generate case law for public consumption? The Act says tribunals are to be held in private. And so the amount of information from them is very limited. Does that mean they don't count as a court under the ECHR? It's hard to know. The WHO has taken these standards and published a book which is free to download. If you punch in WHO Resource Book on Mental Health, the WHO, which is part of the UN, has taken the Universal Declaration of Human Rights and various other things and come up with a series of standards that mental health law should meet. And it's a long document in the book. You can buy the book as well because it's one of these huge PDFs. And it asks a lot of questions about national law. It asks, under A1 there, does national legislation have a preamble to emphasize the human rights of persons with mental disorders? Do we? Does our legislation have a preamble emphasizing the human rights of persons with mental disorders? Has anyone read the preamble to the Mental Health Act 2001 and committed it to memory? Am I right in understanding there are people here from the Mental Health Commission? Are there representatives here from the Inspectorate of Mental Health Services? Do we have service users? Do we have clinicians? Do we have all kinds of people and nobody knows? Shame on you all. I know, but I'm just not saying. Our legislation is very clear in its preamble that it's a piece of legislation for the detention of persons with mental disorders and for their treatment. There is not a word about it being a piece of legislation with an overarching human rights component. So the WHO would not be happy with that. Overall, the WHO asks 175 questions of every bit of national mental health legislation, and there are 27 categories. And I'm going to talk a little bit about how we do. Now I've dumped 9 of the standards because they related solely to offenders or children, just to keep today focused on adults. So I apologize to the child psychiatrists and the forensic psychiatrist who is present today. So how do we do? Well, we looked at this in some depth in the International Journal of Psychiatry and Law last year. Ireland meets 80 out of the 166 standards under the current legislation. That's a mark of 48.2%. Is that a pass mark? For part of my education, 40% was a pass mark, thank goodness, because that just about got me through. But then in college, it went to 50%. So are we happy with this, 48.2%? No, it's not really great. What are the big problems? Oops. Well, as I said, the legislation does not explicitly promote human rights. It does not accord specific rights to families or carers. The position of voluntary patients is not addressed, nor that of vulnerable groups. Nor does it guarantee the economic and social rights that the WHO would like to see it guaranteeing. If we look a tiny bit more closely here at some of the standards, so N means the number of standards that the WHO thinks the legislation should meet. So Ireland, in terms of its preamble, only scores a 1 out of 6. If you look at point B, we've pretty good definitions of mental illness. C, we do really badly on access to mental health care. The legislation does not contain anything about people being entitled to access a certain standard of care. The rights of mental health service users, we get 5 out of 16, and the big problem here is the right to information. This is the big problem within this category. And the rights of families or other carers, we get a 0. And I'm going to talk about that in a quick minute. If you look at the bottom, though, we do pretty good on involuntary admission. And in fairness to the legislation, it is very focused on involuntary admission. That is what the Mental Health Act 2001 set out to do. And it does a pretty good job of looking after involuntary admission. However, if you look at Ireland as a whole, 90% of people with mental health problems are treated in primary care. So there's no question of involuntary admission for them. Of those who see a psychiatrist, 90% are treated as outpatients, and there's no question of involuntary admission for them. And of those who are admitted, 90% are voluntary patients as well. So the focus on involuntary human rights standards, while important, it doesn't affect the majority of persons with mental health problems in Ireland. If you look at the rights of families a bit more closely, it asks, does the law entitle families or primary carers to information about the person with the mental disorder and various other things? And Ireland scores 0 on this. We do not accord rights to family members or carers, and this is a big problem. And it does create difficult situations in tribunals and the like, where family members, for example, don't have any particular right to attend or have their point of view heard, which is a big concern. We don't do very well for voluntary treatments, as I mentioned. And most specifically, the definition of a voluntary patient in Ireland does not require that the patient has capacity. It's just a person who's in an approved centre receiving treatment and is not detained. And the Supreme Court has upheld that this is the right thing, although it's extremely questionable. And the other category the legislation really fails on is the non-protesting patient. This is someone who's compliant with what happens, but probably lacks capacity and just goes along with it. And this is, for example, a person with, let's say, a very low IQ who just is brought to hospital by family or by the guards, not detained, and ends up just sitting there because they're a generally agreeable person, but lacks capacity to protest the way they probably should. If we look at the other categories briefly, we're pretty good in terms of seclusion and restraint because the rules from the Mental Health Commission are binding, whereas in the UK they're not binding. And the final thing, the oversight and review mechanisms is very interesting. We just score 14 out of 24. And interestingly, we get full marks for our tribunals, which are great. The reason we don't do well, according to the WHO here, is we don't have a binding complaints mechanism for people to make a complaint about services or to make a complaint about tribunals. They want legally binding timelined complaints procedures, which don't meet the WHO requirements. And the final batch of these standards, you can see we do very badly in terms of the mental health law prohibiting discrimination, according housing rights, employment rights, and so forth. And when you look at this, for example, the WHO says, does the law ensure non-discrimination of people with mental disorders in the allocation of housing? And our law doesn't go there. And you can argue it shouldn't go there. Surely access to housing belongs in housing legislation and in equality legislation. But history shows very clearly that people with mental illness, particularly schizophrenia, do not access the courts the way other people do. They do not assert their rights. And there's a lot to be said for including a positive articulation of these rights in mental health legislation. But we don't do it at present. Does our law uphold the rights of people with mental disorders to the full range of civil, political, economic, and social rights? And it doesn't. Our legislation doesn't even include a rhetorical flourish in that direction, which could be easily inserted into a preamble. So to summarize, we meet 80 out of the 166 standards the WHO would like us to meet, and those are the chief deficits. And the introduction of proper capacity legislation would help us along the way a great deal, as well as the current revision of the Mental Health Act. But today, rather than just giving out, I've decided to present the solutions to this problem. The solutions to these problems have eluded doctors and social reformers for centuries, but you're extremely fortunate to be here today because I have a 3-point plan. And I'm going to present it now. The best way to increase observance of the human rights of the mentally ill. The first one is to do with social policy, then mental health policy, and limping in a very poor third, in my view, is reforming mental health law. And I have particular reasons for these opinions. If we look first at social policy, a lot of you have probably read this book. Hands up anyone who's read this book, The Spirit Level. Okay, well, in the unlikely event of me being invited back next year, thank you very much. I'm going to ask the question again, and I want every single hand up in the air for this, because this is an extremely good book about equal and unequal societies. And I've stolen all these graphs from it. If you look at income inequality, you've got low income inequality there and high income inequality. A straight line up. The more unequal a society is, the more mental health and social problems, more health problems and social problems in that society. The more unequal a society is, the more drug misuse there is in the society. Now, this isn't about absolute income in a country. It's about inequalities within the country. So it's not about being rich or being poor in a global sense. It's about being rich or being poor in your country. And here it is, income inequality and mental illness. The only exception here is that Italy, it appears, is very unequal, but no one seems to care. It just doesn't seem to matter to them the way it matters to the rest of the world. Let's leave Italy out of this, okay? The more unequal a society is, the more mental health problems there's going to be in there. And this brings me to my big point, which is this book. This is another book everyone has to have read by next year by Sen, and it's about an idea of justice. And I really like this book because Sen is extremely clever, and he talks about an arrangement-focused view of justice and a realization-focused view of justice. An arrangement-focused view means that we try to write the perfect set of laws and regulations and get it all looking perfect on paper, okay? A realization-focused view says, okay, you've got your laws and they're okay, but what's actually happening? Does an improvement in law actually translate into, in real life, what you intended it to do? And Sen says that emphasizing the first, you need a bit of it, okay? But no one knows what the perfect law looks like. We couldn't agree on it between ourselves. And in any case, its consequences are still going to be a little unpredictable. And he wants a shifting of balance to a realization-focused view of justice. And do people feel things have been just? Do people feel they're being treated right? And I think this is really important in mental health law, that we need to move away from trying to get the law perfect and look at what happens in the real world. And here, sadly, is what happens in the real world. This is my stop in 5 minutes signal, okay? So I have 5 more minutes. So we looked at this. We tried to figure this out about Ireland, and we've done this. We've made this paper in this graph. If social class 10 is the lowest social class in Ireland, and in Ireland there's about 19% of people in social class 10. This is all of Ireland, and there's about 42 involuntary admissions per 100,000 per year in that social class in Ireland. Okay, about 39. Sorry, about 39. If we move to St James's Hospital, which is a deprived catchment area, you can see about 40% of people are in social class 10, and the involuntary admission rate is higher. Okay? Now, it gives me no joy whatsoever to show you the next dot here, which is where I work, which is the Mater Hospital, which is the most socioeconomically deprived, with 51% of people in social class 10 and a higher rate of involuntary admission. So this really matters. My point is that social arrangements really matter in terms of mental health problems, the incidence of them, according to the book I showed you earlier, but also there's some kind of socially mediated outcome as well. There's something to do with deprivation, straightforward socioeconomic deprivation. I don't think we say poor anymore. Poor is gone. It's socioeconomically deprived. And there's something about that seems to increase involuntary admission, increase illness, and increase overall problems. And as a result of various social arrangements, the effects of illness, which undoubtedly exists, but the effects are magnified, resulting in a loss of liberty. So in terms of social policy, I see no alternative to revolution. We're going to just have to lead a revolution and change the social order so that people with mental illness get a better bite of the cherry. In the event that no one wants to join me in a revolution today, we can look at changing mental health policy. Now, policy is extremely interesting. Look at this graph. 1963, 20,000 people in psychiatric hospitals in Ireland. 40 years later, in 2003, that was down just around 4,000. Now that's an 80% reduction, all right? And you have to believe that increased the observance of people's right to liberty, okay? How did that happen? Here's another question. What didn't change at all in that 4-decade period? Mental health law. All that was under the 1945 Act. The 2001 one hadn't really started by 2003. So what happened there was society changed, Ireland changed, the world changed, and suddenly 80% of people were discharged, or some of them died, but there weren't new admissions to replace them. What happened there was a huge change, and it was a change in policy. All right? It wasn't a change in law. And people often argue that as the psychiatric hospital population comes down, the prison population goes up, and you can see the lower line is the prison population, and it went up a bit. So there was a bit of that going on, but still there was a huge net liberation of about 14,000 people over that period, and the law did not change. What changed were mental health services, and interestingly, as the asylums closed, obviously the amount of health budget devoted to mental health services declined. But look, it went back up to 7% last year. So there may indeed be some hope yet. So mental health policy is what produced that huge change. And the third way is through mental health law. And without going into it in depth, it's my view the definition of voluntary patient needs to be changed substantially. We need some case law from tribunals. If someone is detained and they appeal a tribunal decision to a circuit court, we need to move the burden of proof, which is currently on the patient. The detained person must demonstrate in the circuit court that they are not mentally ill. Now, I would have grave difficulty demonstrating that I'm not mentally ill. It's very hard to prove you're not something. And certainly, I think we can expect the new legislation to shift the burden of proof back to the detaining authority in the circuit court. There's a principle of best interest in the legislation, and that all decisions under the Mental Health Act need to be taken in the best interest of the individual. There's a strong move to change that. The UN Convention on the Rights of Persons with Disabilities would suggest a principle of dignity is more workable and balanced. And we need mental capacity legislation. Now, I've been talking about this kind of thing for some time, and much to my embarrassment, I've now been put on the expert group charged with revising the Mental Health Act. So we're going to have to put this into practice. The Minister appointed a group. You can see some of the members there. We met for the first time in September. We'll be meeting 4 times before the end of the year, and we'll be advising the Minister in March. And I do believe changes to the law are important, but I believe a much broader kind of change is needed, a much broader societal change is needed if the possibilities offered by our current legislation and by our new legislation can be fully realised. Now, a solution to a lot of this has eluded people for centuries, so it's hard to be especially hopeful, but there's no point being cynical about it either. And hopefully when we report in March, there will be some positive changes to the law. Thank you very much.